So another aspect of ophthalmic ultrasonography is high-frequency ultrasound imaging. I reviewed a fair amount of high-frequency ultrasound imaging with my fellow Flavio Marigo back in 2003, and this is a great survey article if you'd like to read. From an ophthalmic oncology perspective, this was the first time that ophthalmic oncologists were able to see tumors in the front of the eye, particularly in the ciliary body, which is behind the iris. Here we have the cornea, the white of the eye called the sclera, and here's a melanoma that's basically consumed the iris pigment epithelium, and into the ciliary body just posterior. This is a longitudinal section that we learned about, where this is the front of the eye and that's towards the back of the eye. And this is a transverse section, cutting it this way, where we can see the width of the tumor from here to here. This is another tumor. You can see that this is the iris here, and the entire tumor is just posterior to the iris in the ciliary body. This tumor is not visible by gonioscopy, and unless it's over 4 millimeters tall, it's really hard to see with, unless the pupil is extremely well dilated, to see with ophthalmoscopy. These are two examples of choroidal metastasis. This is lung metastasis to the front of the eye, and this is a breast metastasis. And the thing about ultrasonography of metastasis, it doesn't seem to have as much of a mass effect. It's more of an infiltrative tumor. Here are the ciliary processes, and the tumor just beneath it infiltrated and separating this tissue away from the sclera. And you can see it here on the longitudinal section, infiltrating in. This was an interesting case of a young man who came in with these white seeds in the front of the eye. If you look at the B scan, though, it just looks like a disorganized old retinal detachment. There aren't any calcific high acoustic impedance components, but these seeds are diagnostic. On high-frequency ultrasound imaging, we looked at those seeds and we saw that there was lucencies within the seeds, called cavitations, and we could see that the retinoblastoma was covering the ciliary body, requiring enucleation. Once the eye was removed, we looked at the same tissue and saw that the tumor was indeed covering the ciliary body, seen here in blue. High-frequency ultrasound imaging is a mainstay in the practice for looking for intraocular invasion of surface tumors. This is a squamous carcinoma of the outside of the eye overlapping the cornea. Just looking at this, there's no way to tell whether or not it's in the eye. However, on high-frequency ultrasound imaging, in this case a 50 megahertz technique, where you clearly see the cornea and the sclera and the iris, there's no angle blunting, which we see with invasion, or uveal thickening, which we also can see with invasion. Therefore, despite the fact that this is a rather large squamous carcinoma, it has not invaded the eye. Also note the blood vessels on the inner cornea. That's another clinical pearl when you're evaluating a patient who may have intraocular invasion. But most of the time, or the most common thing that we see with high-frequency ultrasound is cysts. This particular cyst is an iris pigment epithelial cyst. The iris pigment epithelium, everyone has a stroma and an iris pigment epithelium. The iris pigment epithelium is behind the stroma, even in blue-eyed people, and it can form a cyst which can peek through in front of the lens. Notice that it's very smooth. On high-frequency ultrasound imaging, you can see it moving forward and being rather large and bowing the iris forward. Here's an example of multiple small neuroepithelial cysts. Neuroepithelial cysts tend to be at the or beneath the root of the iris and against the ciliary body. They tend to have thinner walls, And they too can be imaged with slit lamp biomicroscopy very carefully at an angle on occasion. But in treatment of anterior uveal melanoma, high-frequency ultrasound is invaluable. Here we have a case of ciliary body melanoma. You can see the iris and you can see the tumor peeking out behind it. And the ultrasound shows the tumor mostly in the ciliary body. And here's the transverse section showing the dimensions of the tumor. And here we have it after plaque brachytherapy, after it's been irradiated, years later, shrunken away, measured by ultrasound. So here we have a method to figure out what the dimensions are prior to treatment, so we know what size radioactive device to use, and a way of monitoring the patients over time to make sure their tumors shrink away and remain controlled. This is the way it looked before, just for review. This is a plaque on an eye in treatment of a tumor of the ciliary body. You can see the gold is placed up against the cornea to cover the entire tumor plus 2 millimeter margins. Fortunately, since that time, we developed Finger's amniotic membrane technique, where we put a piece of amniotic membrane beneath the gold on the cornea to buffer the metal so that the patient can be comfortable during plaque brachytherapy. So in conclusion, ophthalmic ultrasound imaging has allowed us to see previously unobservable areas within the eye and the orbit. It has allowed us to use radiation therapy to prevent enucleation, to save vision and life. And lastly, it allows us to learn about the tumors that we image, which is very important. This is one of a series of lectures that I'll be giving online, and I hope they're helpful for you in your practice. Feel free to contact me if I can answer any questions. I want to take a moment to thank you for your attention, and to thank the Eye Cancer Foundation, who supported much of the research presented in this lecture, and for their committed support for international multi-center cooperation in ophthalmic oncology. Thank you and have a nice day.